inviting me to speak here today. Dr. Sechin, Dr. Reich, and the Endometriosis Foundation, thank you very much. And I know I recognize many fellows in the room. I just hear, how many residents are here? We have a few? Okay. So while we're setting up, I'm going to share, I like, speaking towards the end of this program, we're going to try to keep you awake, hopefully, but also maybe tie some things together. And I am a GYN surgeon myself, but I maybe will present, and I love following the last talk. I really don't have to give my talk, actually, no, but I love following the last talk about the issues about, when we're talking about getting, with the purpose of getting pregnant, if we're talking, that the data is very mixed about whether we need to actually operate on these patients. So, I think it's important that we look at this and, maybe have a slightly, different perspective, that it's not just always excise everything, take everything out. And so that's the other thing. Before I start, I just want to say I have a 6+, okay? And though you can't fix the EMR issue, which I don't know why not. But I didn't like your answer. No, I'm joking. But what about the battery issue? I mean, I have an iWatch, but because I never charge it, I don't wear it. but anyway. Okay, getting back to endometriosis. So obviously one of the questions always is, it's not just excision ablation, but it's also, let's say, surgery, medical therapy. We have to always, bring in. It's hard to just talk about one aspect to it, but I'm going to try to focus on mostly that. And the videos are really less important. But it's, this is a little bit controversial. The data is really, there's very little data comparing deep infiltrating endometriosis in randomized controlled trials. There's some data on mild endometriosis. And obviously we have, data was just presented on endometriomas and fertility. But, and certainly, we have to look at this clearly. It's a chronic disease. And again, the tendency, and, don't shoot the messenger, but the tendency when we deal with patients who have chronic disease is we want to treat them. We want to cure them. And I don't know yet that there's a cure for endometriosis. I think that's why we're here. There's different approaches to endometriosis treatment. Purpose is to alleviate the symptoms. We have to address it in a way to, again, sometimes it's organ involvement, sometimes it's not organ involved, the primary symptoms, it's pain. And then again, just like the last talk, sometimes it's all about getting pregnant and fertility, and that's the issue. So we have to look at it and approach it that way. So our options, obviously, observation, empiric medical therapy, surgical treatment followed by medical treatment plus or minus, and then we have the whole issue of ablation, excision, and then ultimately, hopefully we never have to get there, but for some patients the answer is ultimately a hysterectomy. Whether we take the ovaries or not, that's a separate thing. But I'm not going to really go down that path. And I'm not going to talk about all the different options of medical therapy. This is just something for us to talk. Obviously ablation, whether you do a laser, whether you use argon beam, whether you use, obviously we have all different tools, coagulation. And the story is, obviously classically, if we ask the residents, and then again many people in the room feel that maybe ablation's not the greatest way to do it. Okay, well, maybe not penetrating deep enough, and maybe certainly simply we should excise. But we all know that we also hear more and more. I'll just play this as I'm talking. More and more we have physicians who feel that we should be doing on our adolescents who come in with dysmenorrhea, that we should be doing robotic diagnostic scopes with Firefly because we're missing all this mild endometriosis. And I'm sorry, I don't know that that's correct. I don't think we're necessarily doing a service to those patients, but that's just that's me. But it's certainly excision for deep infiltrative endometriosis patients who are unresponsive to therapy are certainly not wrong, and no one's saying there's no right one answer here. And I think that's the take-home message. So clearly we have to be concerned. We have to take a detailed history. And, and what do we care about? Obviously, aside from the symptoms and the patient's past surgical history and such and our physical findings and imaging, but it really is all about what's the age of the patient, what is the primary, problem here? Is it pain? Is it fertility issue, what is the problem? And I think that's really the focus that you have to use when we start talking about what's the best way to treat them. So surgical treatment of endometriosis, again, there's obviously when you search this, and most of this data I'm presenting are, really from the last, 3 years. But there's an incredible number of papers written, but very few randomized controlled trials, unfortunately, when we're talking about this. But patients with infertility and mild disease, there was no difference in fertility rates, no surgery versus surgical treatment. And this, with moderate to severe disease, surgical treatment does improve outcome. And that sort of gets to the point that, again, if we're talking about spontaneous pregnancy, conceiving without intervention, IVF and, assisted reproduction, definitely, surgery does assist in those patients when we still have, good tubal functioning. And then should we diagnose and treat minimal and mild endometriosis before we proceed with, assisted reproduction? Improvement with suppression and surgery have shown little benefit. Most studies show benefit pre-IVF suppression with moderate to severe endometriosis, but there's little data showing any real added benefit. So the question is, when we're talking about specific fertility issues, if we're already this is a patient who's already, been trying to get pregnant for a year and a half, the question is, should we now go and do our laparoscopic or robotic evaluation to see what the extent of disease is, or do we go ahead and just say, proceed with the ART? And then we're going to leave that for all of us, but the data shows that maybe the way to go is just let them have their assisted reproduction. In vitro, and again, this stuff, we just sort of heard most of this, in vitro fertilization, successful treatment in endometriosis-associated infertility. So women with endometriosis have similar success rates with IVF to women without endometriosis. Endометрiomas, again, there is a lower rates of success, but certainly it's still very successful. Just have to go through that. And this was on 2,200 patients. And then I'm not going to, obviously this is just, redundant to the last talk, which was incredibly thorough, and I don't know if we can just skip, but just the endometrioma for improving fertility, again, endometrioma does not appear to have a negative effect on ovarian reserve, but surgery does. I mean, it has some effect, negative effect, but but surgery does have an effect because, again, the AMH and the antral follicles and all that. Having said that, as we heard last time, if we wait long enough, maybe that AMH level does come back. But the clinical pregnancy rate and the live birth rates are similar, and that's the whole key. And again, the feeling from at least this paper, just that, again, get similar to what we heard, is that, the endometrioma is greater than 3 centimeters, should likely be removed. And again, they were saying primarily because it makes it much more difficult for them to retrieve their eggs. And again, endometriosis size is a relevant factor. 60 patients, both ablative excision, reduced AMH levels. Cystectomy, certainly, so excision definitely has a low recurrence rate. Large endometriomas, over 5 centimeters, decrease in AMH is greater in the excision group. Having said that, do I excise the endometriomas? The answer is yes, I excise endometriomas. But again, clearly, we try if we leave the base, if the base is definitely attached, and it tends, as you all know, it tends the hilum, that tends to be the stickiest part of our endometrioma. That will leave and we'll ablate that part. I mean, that's what, so whether, I never thought of it being sort of a hybrid technique, but basically it is. And again, most of the time with endometriomas, you do face, especially large ones, that you face that issue. And then what about pelvic pain associated with endometriosis? Again, treatment of laparoscopy appears certainly to help pain. So surgery, by the way, surgery helps the symptoms. So we're not saying that surgery doesn't help, it does. But no studies have shown advantage of excision over ablation. And having said that, that does not mean that if you have, that you shouldn't excise. I'm not saying that. But when you have patients who have, mild disease, it's the question is, should you be excising and running risk of our complications? And the answer is the jury's out on that. So there's plenty of, obviously, surgeons who think you have to excise, you have to excise, you have to excise. And the answer is, for mild to moderate endometriosis, there's no data on it. So that's really that's at least that I could find. But there's limited studies on medical treatment versus surgical treatment. Both approaches are effective. Okay, medical therapy for endometriosis is growing. There is more options. There are more, progesterones, anti-progesterones, we're going to talk about it. And obviously a lot of research on, different therapies. And there probably will be a day that it's the advanced stage, the deep infiltrative endometriosis, that require specialized, surgeons who are really experienced to do those real excisions when it's involving the bowel. Those are probably going to be the patients that, that will still need surgery. But from mild to moderate disease, I'm not so sure we'll be operating in those patients in the future, but we'll see. But surgery followed by medical therapy definitely is something that you always have to consider and has been shown to, to improve the symptom-free period. And so, again, it's all a question about the choices that we have for our medical treatment post-op. And again, this is, for deep infiltrative endometriosis, meta-analysis, there are very few randomized controlled trials. Many studies show an effectiveness of medical treatment. However, patients with DIE require prolonged, treatment. So if you have, severe endometriosis and pain, we're talking about, sort of very long-term suppression. So surgery is definitely still, and again, is still clearly an option. But we have to make these things options. And again, I often see patients, they look at me because they come to me as a surgeon, usually because I'm in the network, okay? So they may see someone here. And then they come to see me because I'm in the network. So they drive, 45 minutes out to see me. And sometimes many of them aren't happy with what I tell them because I tell them they've never been on medical therapy. They've had 2 radical procedures. And I tell them, you know what? Why don't we see how you do on some medical therapy? And they leave because they don't want to hear that. So it's interesting, and I think it's just something that I hope, especially our young physicians, keep in mind, that you have to bring these as options and you have to tailor what we're recommending. And again, this is similar. All the studies really are sort of tell the same similar story. But surgery works, absolutely helps. Excision ablation improves spontaneous pregnancy rates over diagnostic scopes, and believe it or not, people were still doing just a routine diagnostic scope, seeing endometriosis, not doing anything. But pregnancy rates with excision or ablation have been shown, so doing something at the time of surgery certainly helps the spontaneous pregnancy rates. And again, ablation improved pain treatment over diagnostic scope, plus GnRH. These were, multiple different studies. And then no difference in excision versus ablation. This is for mild to moderate disease. Certainly this was not true. This study, at least I couldn't find, done on deep, advanced stage endo. So clearly those patients, need to have this, excision. And again, this is just, remember, there's a lot of, low-dose progesterones. This was surgery versus low-dose progesterones. 154 patients, they were effective in treating symptoms. And there's similar studies, I can go on and on. Same thing with, one of the studies, actually, I don't think I included, was really just showing, the use of Mirena, the progesterone IUD for patients who have severe endometriosis being effective also. But this one is, randomized controlled trial, hormonal therapy versus surgery versus combined therapy. And these were done with, second look scopes. And, 60% were cure with the combined treatment, 55% hormonal, 50% surgery alone. But again, no significant difference among groups as far as pregnancy rates. But again, the various modalities we have tend to be effective, and I'm going to skip over some of this so we get to the last bit. But consensus on current management. Okay, this was the World Endometriosis Society Consortium. This was in 2013. No significant difference in outcome of excision over ablation. However, excision is recommended for patients who have deep infiltrative endometriosis. Evidence is still controversy regarding best first line. And it's felt that actually medical therapy should still be offered as an option for first-line treatment. We should try it. If you do well, and again, it depends on what your plans are. Obviously, if you want to get pregnant in 2 months, it's not going to help. But again, if that's not the goal, medical therapy is definitely an option. And then most adolescents have stage 1-2 disease. Due to lack of evidence, balance between appropriate treatment, empirical, medical versus surgical, without over-interventional approach must be recommended. We have to remember for our young patients that the data isn't really out there yet that says we should be going in there and doing peritoneal stripping on all their on all their endometriosis. It's not there yet. I mean, maybe the studies need to be done, but it's not there. So first-line treatment, remember, is, NSAIDs, OCPs, oral progesterones, and then second, GnRH, the progesterone IUD, danazol, depo-progesterones. We have aromatase inhibitors, today's SERMs, and also selective progesterone receptor modulators. And again, the list is going to continue to grow because obviously there's more and more data, coming out there. So just remember again, what's the objective? Is it conception, pain, restoring organ function? That's really key to what we're advising the patients, and we have to address, the main clinical objectives, not just the presence or absence of visible disease. All right, hopefully that wasn't too quick, but you were standing there, but thank you. I always have, I don't know if you've seen the logos and the commercials, but our new name, I'm from North Shore, IJ. I can't say that anymore, I'm from Northwell, but you're supposed to look north. I'm not sure what that means, but anyway, any questions? Anyway, thank you very much.